before we begin, I just want to make sure that everyone is aware. I'm using a composite case study throughout to illustrate the clinical significance. It does bring up a lot around sexual trauma and sexual assault throughout the lifetime. If it is too much, etc., I'm going to say just communicate with Bonnie if you need to step away. I completely understand. It is heavy. And then, of course, this is a safe space. I expect that everybody will be respectful and treat as particularly the case and if anyone else shares anything with confidentiality. And obviously you guys signed up for this, so I'm assuming you know that we're going to be talking very explicitly about suicidality. So again, if there's something that's incredibly triggering or something like that going on, just, take care of yourself is my number one point here. I think that that's the most important thing. So yeah. These are our learning objectives. Assess relational wounds that underlie symptom expression and identify ways therapeutic alliances can serve as corrective emotional experiences for clients. Quite the sentence. Apply ethical principles that balance client self-determination and clinical responsibility to ensure safety when treating the intersection of OCD and suicidality. Describe and integrate trauma-informed treatment modalities for managing complex clinical presentations. Great. Okay. If there are any particular learning goals, questions, before we jump and get started, please throw them in the chat. All right. And if there's anything in particular, I'm going to open the chat now. Anything in particular that you are hoping to learn, throw it in there and I will hopefully be able to cover it. So what do we know? When we bring up suicidality, what comes to mind? Again, would love for people to throw some things in the chat. As interactive as possible. What are the words that crisis, right? Truly. I hear from a lot of people, the first thing that comes to mind as a clinician is like overwhelming anxiety. And so I like from the clinician standpoint, I think that that's interesting. Desperation, depression, trauma, pain, stress, hopelessness, connection. Yeah, triggers, all of them. Burdensomeness. Oh, that's a great word. Inpatient hospitalization, which I think also tends to trigger the clinician in the situation. Oh, out of options, low self-esteem. Great. What about OCD? What comes to mind when you think about OCD? Rituals, rigid thinking. Somebody said we don't know enough, and I could not agree more. I like to say that OCD is one of the most well-known mental health diagnoses. It's one that we use all the time, in terms of like, oh, I'm so OCD about that, or like, oh, like that's like you're so OCD about keeping your room that way, or whatever. But it's one that we actually know so little about, neurologically, clinically, genetically, all of those things. It's actually really fascinating how little we know compared to how often we just throw terms around. Who here has treated or treats OCD and trauma concurrently, if anyone? I love that. Love it. All right. So, okay, okay. As I said earlier, like this came out of my clinical work. All of these things have been researched independently. All three of these things have a fairly large body of research, even if we're still very in the dark when it comes to OCD. Um, However, when I went to find things on this as I was treating clients, what I found was absolutely nothing. I could not find anything that really captured all three of these pieces. And so I actually went to quite a few different people, any expert that would listen to me or talk to me, I would ask. And I kept getting the exact same reaction from every single one of them. And, and they said, you should really write about it once you figure it out. And I was hoping they were going to tell me something useful. Most of them did not. So this is one of my favorite quotes about OCD. Their care is one of the most arduous tasks that can fall to the lot of physicians of souls. Even as these poor creatures are ever tormenting themselves with the self-same scruples, they fail not to torment their confessors with the never-ending repetitions. It is arduous because this malady is one from which few recover completely. If they go not mad themselves, they will at least make their confessors go mad. This is from a monk in the 1700s. And he was treating OCD, but and honestly, like one of the things that I think is really cool if you like look back at this is that the clergy who treated OCD back then were also using behavioral and cognitive strategies a lot. But this is also what makes this is what makes, I think, being an OCD therapist particularly challenging is sessions can go in circles and over and over and over and over again. And the people in their lives, right? Like it can really create some ruptures in their relationships as well, because people aren't able to listen to them anymore. So OCD. These are three of my favorite quotes. OCD has taken so much from me, leaving me feeling broken and lost. I find it profoundly scary to not be able to choose my thoughts. And it is also just exhausting and infuriating. When it's happening, you feel like it will never end. OCD is not a disease that bothers. It is a disease that tortures. When we're looking at this with attachment trauma as well, a lot of times we're looking at people who have experienced really difficult things, particularly trauma. And then on top of that, there's this piece of like feeling like they can't control their own minds, and leaving people feeling incredibly misunderstood. This is also where I like to point out that there is more research coming out around OCD and intelligence. And so generally speaking, they believe that people who have a diagnosis of OCD also have a higher intelligence. This is done through like IQ testing, and don't get me started on that. But one of the things that is really cool, and you can look it up online, Yale did a study of brain scans of people with OCD versus neurotypical brains. And the OCD brain is just lit up all the time, like at rest, at inactivity, and during sleep. It's just always lit up. And that's something I use a lot with my clients of just like, yeah, your brain is actually really, really active. And we can say that confidently. So quick facts, impacts 2 to 3% of the population. This is, research indicates it takes an average of 13 years for someone to receive an accurate OCD diagnosis. 13 years in treatment for someone to get an accurate diagnosis. High misdiagnosis of anxiety and depression, and occasionally psychosis. But that's a very long time. Around 50% of individuals with OCD experience suicidal ideation, with a significant number attempting. The ability for one to emotionally regulate is not only significant in managing the ideation, but also a crucial component of the OCD treatment. We also know that around 82% of people with what they like to call treatment-resistant OCD endorse a history of trauma, usually a pretty significant interpersonal relational trauma. So I think makes a lot of sense to me, having worked in trauma for so long. But I think that that's a thing that gets missed a lot of times when it's treatment resistant and people are doing whatever they do. I am not going to spend too much time on these things, but I want to go over, just what treatments we have for OCD, because they inform the treatment portion of the conversation that we're going to have. The gold standard for OCD is exposure and response prevention, born out of CBT. There is extensive research on the efficacy of ERP. Really important, because short term, those studies say this works amazingly. This is wonderful. However, long-term follow-ups have not shown the same results. There's more and more research coming out about what the long-term results are, and people coming back to therapy at certain points. Highly effective in the short time, can't really use it to protect or predict long-term remission. Generally speaking too, a lot of people refer to OCD as a lifelong affliction. And so under that particular window of a lifelong affliction, they say oh, well, OCD can never be cured. Sure, no. And in many ways it is. But that is still problematic if our treatments aren't continuing to work throughout the lifespan. We need to look at that. Also, the idea of a lifelong affliction often contributes significantly to suicidal ideation. Because if somebody is doing their own research, or they start talking about it, or whatever it may be, and somebody's like, well, yeah, you're gonna have this for the rest of your life, that sounds like the worst thing ever. It is, like many of you put in the chat, it is hopeless. It feels incredibly hopeless. So while that may be true, that this is an ongoing thing that many people do in fact have to manage, it does not usually stay at one particular space of intensity. ERP, CBT, very specific treatment phases: emotional regulation, distress tolerance. You create an exposure hierarchy or an exposure ladder, work through it, and then integrating all of the things you have learned back into normal life. While, all of these things are really important, a lot of people go about OCD treatment in a very non-relational way, and much more of a prescriptive way. We know this works. Here you go. Do it this way. Best of luck. Yeah. Metacognitive therapy is also one that has been, I would say, integrated pretty heavily into the ERP and CBT treatment. It is very handy because its entire thing, particularly what we use, is attention training technique. So you practice shifting, dividing, and selectively focusing your attention, usually utilizing external things to shift that attention. And it helps reduce rumination, worry, all of those things. Detached mindfulness is another metacognitive therapy principle. So people call this different things. One of them is a mental event. Other people talk about like naming the OCD. And so when the OCD pops up, you're like, oh, that's just my OCD. But more or less, the idea is obviously metacognitive. You are thinking about what you're thinking and viewing those things as a differentiation of yourself versus who you are as a person. It also really helps in decreasing the thought action fusion. So just because you think it doesn't mean you're going to do it. And a lot of times people with OCD have a really hard time with that piece. So it's really handy. Some of these strategies are really handy. They also, MCT is where a lot of OCD treatment gets its worry loops and worry tapes, or worry time, where you have somebody read their list of what ifs, and then you have them listen to it twice a day for 10 minutes. And for kids, this works incredibly well because kids get bored really easy with their own thoughts. And so, it can like speed up the process a lot. Adults don't love it quite as much. However, it does work. And most of the teenagers I see are very reluctant to do it. But when they do it, it tends to work. So a lot of MCT. These are just the 5 principles, more or less. So changing thinking, attention training, so identifying also the worry, rumination, threat. What are those things? Why do we have them? Why do we use them? And having clients sit down and think about what that is. So while MCT is really helpful in OCD treatment, it can also be incredibly unhelpful in trauma treatment, because the threat has happened, right? Like the bad thing has happened. We're not talking about it in probabilities or in possibilities. It's happened. And while we can use some of the attention and shifting attention techniques, it's often really hard to do, especially with attachment trauma, because this is most likely how the person in front of you was raised, which means that this is how they're thinking. So also where a lot of OCD treatment gets it wrong. I'm going to take a second and look at some of the chat. Familial and genetic components. We know some, but we need to know more. We know it's genetic. There have been studies done on twins, fraternal and identical twins. And there is definitely a genetic component to it. They also, like, if a parent has OCD, there's also a higher chance of a child having OCD. And there's a lot of argument about whether or not that is learned behavior or genetic. So, the never-ending debate of the nurture versus nature, more or less. But there is a genetic component. there are a few studies out there on it. There are particular genes that they have identified that turn things on and off. Um, I think that's also one of the reasons why people don't necessarily look for trauma when it comes to OCD, because they're not thinking of it in those terms. Like, they're thinking of it more organically than situationally. So that's my 2 cents. Lack of long-term, yes, the lack of long-term efficacy, because ERP and CBT only treat symptoms. I think that's accurate. That's how I conceptualize it. I don't know that there's actually anything out there that is that has stated that explicitly. But I think that that's the underlying belief. And you know what? If it is just symptoms, right? Like, for some people, we are talking about symptoms, then yeah, it's going to work really great. But it is not going to work really great when we have underlying causes. And, maybe we're also like forcing someone to do exposures, and we don't know that we're exposing them to their trauma, and we haven't done anything to help them manage that at that point. So problematic. Somewhat. If a child presents with OCD early on, can the symptoms dissipate over time without treatment if they're with shifts in their environment? Somewhat. So if you're looking at a lot of reassurance seeking, parents being like, I'm not going to do that, and stepping in and shifting that environment very quickly, can and will shift the OCD. A ton of OCD treatment is also done at home, especially with kids, because you get them for what, 45 minutes a week, maybe 45 minutes twice a week. But where all these things are happening is at home. And so, it's saying like, no, we're not going to use this particular thing. Or no, like, you can't use plastic silverware every meal because you don't trust the dishwasher, whatever. So if parents shift and parents are able to make that shift early, yeah, you're going to, like, you can see a real change. And especially if you have parents who are emotionally attuned to their child, you will definitely see some shifts, because then you have parents who are able to validate the feeling while also challenging the compulsions and the obsessions. However, again, if we're looking at attachment trauma, you probably don't have that consistently. And so it's probably gonna go unnoticed, one. But two, you have parents who are not necessarily, or caregivers who are not going to step in and do the at-home work to change the outcome. There's a very big debate about medications. Yes and no. Some people say that the medications are causing tics, and cause more like body focused repetitive behaviors and things like that. However, there is some argument that medications can and do create some of these symptoms. I'm sure most of you have heard of PANDAS. I can never remember what it actually stands for. But basically, the symptoms are very OCD, like it is OCD symptoms, but it's caused by a strep infection that has usually gone untreated for a very long time. And I've treated it a few times, and honestly, between antibiotics and using good old-fashioned ERP, you can get somewhere pretty quickly. And also, like, if we're talking about like some of those other pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. That's what it stands for. There's a reason why I can't remember what it stands for. So it is very, it has its whole own thing, and there's a lot of people studying that as well. But in some of those cases, because we're looking at like something that can maybe be medication induced or something that is infection induced, we're not necessarily needing to look at all the other, I mean, I always say assess for them, please, always assess. But we're not necessarily looking for those underlying causes, and usually ERP and CBT can be quite quite effective because there's not actually that much to treat underneath the symptoms, if that makes sense. No. So I don't know how many of you have heard of inference-based CBT. This is usually my chosen path of treatment, especially when there are like other factors coming in, not necessarily attachment trauma, but other factors. So first of all, their website is amazing. They have so many free resources. Their entire workbook and exercise book are both online in English and Spanish, and I want to say maybe French, maybe another one, but completely free. If you look up inference-based CBT, their website will pop up. They're a love time. So inference-based CBT is developed by Frederick Artema and Dr. O'Connor. So it targets faulty reasoning and how we get to the faulty reasoning over just targeting like the thought or the obsession. So it proposes that obsessions arise from imagined possibilities. What if I contaminated someone? What if I accidentally hit someone with my car? What if I jump in front of this train? Fill in the blank. And those things override that sensory evidence. Treatment, the goal of treatment is to identify that inferential confusion, reconnect with the present moment, disengage from obsessional doubt, and we do this primarily without relying on exposure, which is great. This is one of the reasons why I like it. Yes, exposure works in many, many situations and it's great. This one does not rely on exposure, but we still get to the root of the issue. And that's the other piece of this is like, we're actually usually going a little bit deeper and hitting the root. What is the faulty reasoning? And whenever I've used the term inferential confusion with a client, it's like a light bulb goes off in their head and they're like, I don't even know if I know what that means, but I'm pretty sure that's what I'm experiencing. So then we, go into that. But they're not like it. That's what it is. What you were experiencing on the outside, what your sensories or what you were sensing, what you were intaking does not match the fear, does not match the cognitive piece of your brain, and what your brain is trying to tell you. Is there any data to show if exposure, if you ask someone who does ERP, they're going to tell you ERP is what works best, and no debate, like, okay, this is great, and they might pull some things from it, but ERP, CBT work best. If you ask someone who has gone through inference-based, who has been trained in and provides inference-based CBT, they're going to tell you inference-based CBT is more effective. So I don't know that there's actually, at this point, I really don't know that there's research that would say one helps more than the other or one is more effective than the other. However, both of them have very high rates of efficacy. And at this point in time, um, I I think from the latest thing I read, inference-based CBT has a longer lasting impact than ERP. Um, but yeah, there's always bias, there's always bias for who's using it, and those people are probably going to be able to find some research to back them up. Um, so yeah, it depends, but long-term wise, there has been much more long-term reprieve, like that the treatment has lasted longer. And a lot of people think that that's because, I mean, we're dealing with some things underneath, like what is bringing about the faulty reasoning. But that you're also teaching skills that are different than ERP skills. So the skills are not like do this, do this, do this. It's more like, okay, let's work through this. Let's reason through this. And the worksheets and all of those things are also available to clients long term, like because they're free online. And so they can also just like go online and print something out. And it is from them, it's from their website. It has not been tampered with in any way. And so there's also the resource around it is also really great. And I think my impression is that a lot of people believe that that also contributes to the long-term remission. So, oh no, that's not what I'm wanting. So these are just the, oh no, sorry, my slides got mixed up. I was afraid that was going to happen. Anyway, we'll move on. This is taken from the ICBT website. This is their circle of the obsession compulsion roadmap. So you have your trigger, the obsessional doubt comes in. What if, what if, what if? And then, oh, feared consequences. That's where your brain goes, oh, no, 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 what, blah, 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 blah. My whole family will die, or I'm going to go to jail because, I don't know, I committed insurance fraud as a therapist. Now I'm going to jail. Then the emotional reaction, your brain is releasing the adrenaline, the cortisol. It is flooding your system, usually in a very rapid and very intense way. And so your entire body, you are having sensational reactions along with emotional reactions, hence the compulsion to try to bring that down. And then we just keep going, because also our brains can come down off of something a lot faster than our bodies. So we can be moving on and our brain can be like, yeah, but why does my stomach hurt? And now we're back, like, oh, my stomach hurts because I had this thought, and now I'm going to jail and whatever. So that is a very big part of this, is also like noticing the sensations and what's going on with the sensations. And then also targeting the sensations. Yeah, really good stuff. I really love ICBT. I actually use it a lot, not just necessarily for OCD treatment, because faulty reasoning shows up in a lot of places. And so, I find it really helpful on many fronts. They have more or less like 12 sessions. I've never completed it in 12 sessions. It's always been longer than that. But the 12 sessions are like one is assessment and model introduction. Session 2, you identify reasonable doubt or obsessional doubt. You really map out the what ifs and the doubts of that. Session 3 is understanding inferential confusion. Identify how imagination overrides sensory evidence, which is honestly one of my favorite sessions. Session 4, reality sensing versus imagined possibility. Differentiate actual perception versus hypothetical scenarios. 5, out narrative. You break down, and this is like this one reminds me a lot of TFCBT, because you're breaking down the step-by-step, you're breaking down the story step-by-step, that generates the obsessional doubt. So also this can be really helpful, especially if we're looking at a single incident trauma. I mean, it can be helpful for more than that, but this is really great for the single incident or one-off freak accident trauma, because it gives that processing piece, but it is not complex PTSD that you're trying to conquer with a narrative. 6 is vulnerability themes. Identify personal themes, usually responsibility, contamination, morality, that fuel doubt. Those are very important. So once you get your theme, you can great things. 7 is reasoning errors. 8 is reconnecting with your senses, strengthening trust in present moment sensory information. I also use this one a ton outside of ICBT and outside of OCD because it's a really great grounding experience. And so I use it all over the place because grounding back into your senses is a thing that most of us need to do more often than not. Session 9 is crossing the bridge to doubt, interrupting the mental shift from reality to imagination. 10 is reducing compulsions. 11, generalization, apply ICBT reasoning skills to new or residual doubts. And then session 12 is relapse prevention, reinforce trust and perception and prepare for future doubt triggers. Really, really good stuff. I think, yes, so if you, I think Bonnie's grabbing the link, but it's just ICBT, I think, or inference-based CBT. If you type in inference-based CBT, it will most likely be the first thing that pops up on a Google search. Once you get past Google's funky AI thing. But yes, I will, if we can't find it here, I'll make sure it's included with the slides. So. Treatment limitations. One of the main treatment limitations, yes, that is it, Bonnie. Thank you so much. One of the main treatment limitations is racial discrimination. So this study always, like, I reel from it. And again, it goes to 2008, so there's newer research out there. But at that point in time, and the numbers are still not that far off of this, 91.5% of participants were white European Americans, which is a lot of people. And so that has been an ongoing, that's been an ongoing issue within OCD treatment, is because we're not, like, we've really studied white boys, is what we've done most of our research on. And we don't know, we don't know what cultural implications there are. We don't know if something shows up differently here or there. We just don't actually know. But I find this disturbing. This is from a couple of studies. OCD symptoms, severity, and disability do not change across populations. When we have looked at OCD in other populations, we see that the distress and the severity doesn't change. Those two things are still there. Non-minorities are around twice as likely to receive therapy, ERP, and medication. Minority populations were twice as likely to have never taken medication. And the first study on OCD in African American youth was published in 2016, which is 10 years ago. There are more that have come, but not nearly as much as we need. The limitations are great, are vast. So one of the things too that goes with the treatment limitations is we have seen that people of color are diagnosed with more significant or more severe mental health diagnoses when the OCD is gotten wrong. When they looked at it, white European Americans tend to get anxiety and depression as their number one diagnoses, while people of color get personality disorders. Or I had a little boy who had OCD that I saw for a very long time, and he had been diagnosed with conduct disorder, or not conduct disorder, ODD, oppositional defiant disorder, because his teachers were like, he just doesn't listen. He never listens. And like, come to find out, this kid is like going through so many mental compulsions every day. And there's a reason why he wasn't listening. Very frustrating. And there's actually been confirmed cases where somebody had OCD and they were diagnosed with psychosis or schizophrenia, which whole thing, that's just absolutely tragic. It's absolutely tragic. Yes, it is a reach. I really want to know. I want to know who did that. They were not named in the paper I was reading, clearly. But right, like, because OCD can present in so many different ways. I mean, you don't have to have physical compulsions to have OCD. You can have mental compulsions, and mental compulsions can be just as debilitating, sometimes more. And so because there's not always a physical compulsion, people will get diagnosed with other things, told that they're just overly anxious or whatever. So yeah, the limitations are problematic. There has been very few studies on the efficacy of any OCD treatments outside of generally white European Americans. Also very problematic. There is more research coming out in what they are referring to as justice-based CBT. And justice-based CBT basically looks a lot like TFCBT. And the shift in it, though, is that like the beginning of the therapy is really focused on like cultural beliefs, how things play out in a community, how things look at this point in time, or what are your beliefs, spiritual, religious, whatever. What are these beliefs around what's going on with you? So there's more coming in that sense. But everything with justice-based CBT at this point, and the people who have been working on it have done research around just trauma and OCD. Their trauma, though, that they are mainly looking at is more single incident trauma versus complex trauma. Yeah, so I am loving the chat. I refer to ODD as the lazy clinician's diagnosis, because what does it even actually, like, what does it mean? What does it even mean? I yeah, ODD presumes malintent. I think that is a great way of putting it. Jennifer, I'm going to give you credit. All right, so I'm going to take a little moment here before we jump into suicide, because I know I just threw a lot of information at you. Any questions that we have not gotten to? Any concerns, thoughts? All right. Keep throwing things in the chat. That's a great question. OCD is no longer under the umbrella of anxiety disorders. Well, in the DSM, it is now its own category of obsessive disorders, or disorders of obsession, or something like that. And it has, yeah, it's been moved to its own thing. But it was under anxiety disorders until the DSM-5. Yeah, they keep moving it around, so it is confusing. Acceptance and commitment can be an appropriate model. It really depends on the client. Some clients really take to the ACT model and love it, and like the acceptance piece really works for them. Other people, the idea of trying to accept any part of this feels like death. Like, if they accept any part of this, it is the end. If they accept any reality, it is the end. And so it can work really great for some people. For other people, it is not the way to go. But again, right, like, I mean, I'm also coming from a point where, like, when I have gotten highly traumatized clients and then I discover through a lot of assessment that they have OCD, there have been points in time where I'm like throwing anything and everything I can like figure out, because there was nobody telling me, there was nothing I could do, like what to do in those situations. And so, like, yeah, if I pull from ACT, I've pulled from this, I pulled from that, anything that be like, well, we'll see if this works. No. Yes, anxiety does play a large role, and hence why it's misdiagnosed as anxiety quite frequently. It looks like anxiety in a lot of ways. It looks like a generalized anxiety disorder. Like, this person is anxious about the most randomish, we don't even know what, half the time. Or like they're completely obsessed with this thing that doesn't make any sense, but they're having all these symptoms of anxiety. The other thing too is when you have thoughts that are deemed inappropriate, people don't tell you. People don't tell you that they're having those thoughts, even if they're in therapy. And so then you may not know that these obsessive thoughts even exist because they're not telling you. A really common one is pedophilic OCD, especially with groinal response. People don't want to tell you that. They don't want to talk to you about how they're afraid that they are a pedophile because they have obsessive thoughts about it, and they are having a bodily response. So there is, like, that's also part of why there's such a large misdiagnosis as well. And I've also had people who I've met with for a long time who have been treating OCD in one vein, and then one day they're finally like, hey, I have reoccurring violent thoughts intrusive thoughts about like murdering my children. This is what I've been doing to, like, these are the compulsions I've been doing, more or less, to ward off against that. And so, sometimes it just takes time. Sometimes people come in and they're like so distraught that they're like, word vomit, please help me. So it is very unique, but very anxiety producing. Um, has any correlation been found between certain religious groups' teachings and practices in OCD? Why, yes, there have. This is another paper I'm currently writing. Scrupulosity is the term for religious OCD. It comes from the idea of people having religious scruples. So there has been a very high correlation between scrupulosity and high control religions. So what I have been looking at mainly are, or what I've been looking at mainly is like purity culture in like evangelical Christian society, and how purity culture has actually like really impacted a lot of women who then present with scrupulosity. So very fascinating stuff. It doesn't like those two things like best buddies. Because OCD, you're looking for something usually that's like black and white. Like you want something to tell you exactly what to do. And then you're given usually a very clear roadmap of like, this is what you do in religion. This is how you succeed in religion. And so the OCD brain just really gravitates towards that, really likes it. And then, you know, when the fear of hell is put in you, now you have a thing that is beyond fear inducing. You're so afraid, and it may sound completely ridiculous to whoever you're talking to, especially if they don't have a basis for religious OCD or religious trauma. And like that's one of the other things that makes it particularly hard is not only are you dealing with a belief system, so like exposures might be out in some cases, but you're also dealing with a thing that is not like we can't define hell. Like we can define jail. We can talk about jail. We know what going to jail can look like more or less. I use going to jail because that's a very common OCD fear. But we can't necessarily define hell in the same way, if that makes sense. So lots of that. I really love that topic. Have a focus group going. Really excited about that paper. Yes, you can have obsessions without compulsions. That was a change, I think, in the DSM-5, because you can have mental compulsions. So, or I guess you can have OCD and obsessions without physical compulsions or noticeable compulsions, because there are mental compulsions and other ways of bringing all of it down, other ways of managing the stress without just compulsion. So this is actually a wonderful segue very quickly. So most people are afraid of possible consequences of talking about those type of thoughts. This is a hill I will die on. Yes, please assess, always assess. But do not call CPS on your client who is having an OCD moment, because now you are validating that their fear is real, that they could do it, that they are capable of it. 1. 2, because it's not actually a threat, you are in fact breaking confidentiality. And this is one of the things that I didn't even know people did this until I saw a post on one of the like therapist boards, and somebody was like, yeah, so like I called the police on this guy because he was saying he was having thoughts of like violently murdering his girlfriend. And everybody was like, okay, like, but what? And she was like, well, he has OCD. And, you know, it was just really graphic. We're like, yeah, but was he gonna do it? And she was like, well, I don't know, but like I called the police on him. Assess. Use your assessment skills. And if you don't have the skills to assess for that, find someone who does and talk to them before you call the police on your client. Because you also, especially if you have a client who has pedophilic OCD, again, assess. And you could get them into so much trouble over something they already are so afraid of. And also you're breaking confidentiality. So throw that out there. There is an SVU episode that I really have a lot of problems with, where a kid comes in because he's so afraid he's going to sexually abuse his brother. And they determine he's a pedophile in the making and blah, 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 blah. And there's like all these things. The whole time, somebody told me to watch it. The whole time I watched it, I was like livid I was just so livid. I was just like, are you kidding me? Like, of course they turn this kid into like this whole thing. But if somebody is terrified of committing the act, most likely they're not going to do it. And that's usually one of your signs. Like, how afraid are you of the fact that you're going to do this? If somebody's truly afraid that they're going to do it, they're most likely not going to do it. That makes sense. Yes. Where does the line end with that? There doesn't necessarily, the active in detail doesn't necessarily mean anything. I assess for how distressing is this thought? How afraid does this person feel of this thought? And also, like, if you're talking to somebody who has had absolutely zero history of violence in their life and they're talking about this, or like this has never been a problem and they're talking about this, you put the pieces together in terms of like, what does the history I know of this person tell me, and how afraid are they? I have treated pedophiles, and I will tell you, some of them are sorry. Not one of them was ever afraid of hurting a child. They weren't afraid they were going to hurt them. They weren't afraid that they might ruin a child's life. Some of them, through treatment, became remorseful, etc. However, they weren't afraid of it. Usually I do limit documentation on obsessions, 100%. I've been into court more than I would like to know. So I limit all of my documentation more or less. But like I might say like client and therapist worked on X, Y, or Z, or client endorsed thoughts consistent with pedophilic OCD, maybe. But usually even then I'm like, I put it under sexual OCD. So it's, yeah, I definitely limit documentation because of just the implications. It's a hard call, and it does take, I think it's a hard assessment call, but so important. Like, I think that this is one of the things that gets messed up more than it should. And also because we're not necessarily taught as clinicians like what to do in these particular circumstances. Yes, I also recommend doing a reality assessment. And if like you're truly concerned, do a reality check. My thought on it is like, can you ever assess like too much in those situations? And usually the answer is no. And I'll even tell clients like, listen, I'm doing this assessment, not because I think you're going to do it, but because I need to for X, Y, or Z reason. Or you know what? We're going to do it because I want to show you where you're at on this thing. The one, so there's a thing that we do a lot of times in OCD that we say, like, somebody will say their fear and it's like, oh, it's always possible. Like, what if my parents die in a car accident? It's always possible your parents die in a car accident. If you have someone who has pedophilia OCD and they're like, I'm afraid I might touch a child, and you're like, it's always possible you might touch a child, they generally lose their minds. Absolutely lose their minds. And it sounds really counterintuitive, but anything and everything is possible. And that is one of OCD's favorite ways to get into people's head, is like, it could happen. It might happen. Like, yeah, a piano could fall from the sky and land on my head because, I don't know, they're moving a piano from one embassy to another here, right? Like, who knows? Yes. So not probable, highly possible. Or not probable, not possible. So I'll even say that to them. Like, is it possible? Yes. Is it probable? Absolutely not. I don't know if somebody has ever been killed by a piano falling on their heads. I'm assuming somebody somewhere has. However, not probable. However, we do have to also live with the possibility of it. So pedophilic OCD is really, it's a challenging one because, again, like exposures, can't really do exposures in the same way that you might in other ways. So a lot of it is talk therapy, obviously skills and all of that, but usually for somebody who is experiencing pedophilic OCD, the just the talking about it is so incredibly triggering. And so in so many ways it's harder, but in other ways it's actually easier, because you have a lot of content to talk about in your sessions, and you also get to talk about it with them as they are distressed. So you are there able to coach them with the coping strategies, etc., while they're freaking out. The other thing, so most people who have pedophilic OCD will stay far away from anything and anything involving kids. Sporting events, markets, right? Like anything that they will try their hardest to stay away from anywhere that involves children. And so one of the things we do as an exposure is, like, you're going to take a walk around your block when school lets out. Are you going to do anything to anyone? Is it possible? Yes. Probable? No. But taking a walk around the block when children are out and about is just really overwhelming. But they do that, and then they have this space of, oh, like, I didn't do it. I didn't follow through on my obsession. Or and most of them don't even like the word obsession really bothers people with pedophilic OCD for good reason. So yeah, that's a very quick overview. There have been books and papers and entire conferences dedicated to the treatment of pedophilic OCD. Practical way of setting realistic expectations. The way I put it to most of my clients is, right now OCD is driving the bus. Our goal is for you to be driving the bus. OCD might still be on the bus. In fact, it probably will be from time to time, but it's a bus. So the OCD might be all the way in the back. The OCD sometimes might move closer towards you, but you are driving the bus. You are in charge of your thoughts. You are in charge of how you respond to these things. And so I use that framework because most people with OCD, it does not go away. It's not treatment does not make it all disappear. It's about managing. It's about managing all of these different pieces, which is, not that different from any other diagnosis in a lot of ways. So I really focus on like, we want you to be in charge. We want you to feel in charge versus your OCD feeling in charge. And then as treatment goes on, I also am very clear, like some days the OCD is going to feel in charge and like you're going to have bad OCD days because unfortunately you're a person and people with OCD have bad OCD days. It's about what you do with it that counts. If you curl up in a blanket and hide under your couch and refuse to talk to anybody, it's going to get worse. We know this. If you move your body, if you get up, if you go for a run, etc., whatever it may be, it is going to be better. And I mean, one of the best things you can do for OCD is exercise because of that adrenaline and cortisol response that happens in your brain and body. And so that's a way to release all of that, instead of it just like hanging out there. Yes, many cartoon characters have had pianos dropped on them, which is why I used it. I used to say an anvil, but younger people did not know what I was talking about. So, a lot of OCD is there's a lot about you feel like you're making it worse before you make it better as a clinician, unfortunately. Discern about talking versus co-ruminating. Great question. So for the talking piece, you are the person that has both feet in reality, is ideally. As a clinician, you are grounded. You have both feet in reality. You can also say to someone when you're like, okay, I think we're just ruminating, like, I think we're co-ruminating. You can say like, okay, we're not going to talk about this anymore. Like, we've talked about it 4 times. We've been through it. We're not going to talk about it again because talking about it again isn't going to get you anywhere, like, clearly. So like, let's shift to this thing or let's shift to that thing. Tell me about this. Or sometimes I'll actually have I've had people sit there and just tell me the same obsession over and over and over and over and over again. And by the end of session, they're usually kind of bored of it because they've been talking about it nonstop for however long. So you can use the worry loops. You can use some of the metacognitive therapy to really help pull that out, from co-ruminating to co-regulating. Is how one of my supervisors put it one time. So, when someone with OCD talks of recurring thoughts, fears of hurting a child, wouldn't there be a strong chance that it had been reported before? Yeah, you can ask if it's been reported before. And yeah, and that's right. Like, you can be like, okay, so factually, this has been reported before. Nothing happened. You're good. It would be screened out. Just don't get too close to reassurance seeking or reassuring. So reassuring in a small way, but not going all the way to like, okay, but like, we're going to reason out how this isn't going to happen because X, Y, or Z. Usually these thoughts are not rational. And so we're going to move forward. We're not going to stay here. In fact, if somebody was like, but it was reported, and so I don't think anything's going to come of it, but what if something comes of it? I would probably at some point eventually say something along the lines of like, oh, maybe they lost the paperwork and they're going to find it later. You are also trying to bring out distress, right? You are trying to push through some of those things. A lot of OCD treatment can feel really counterintuitive. But you also have to have a relationship with somebody to get to some of those places. Thinking of covering mandated reporter status. Yes. So the difference I say is, are they going to do it? Are they telling you they're going to do it? Or are they afraid of it? Because if somebody's like, I'm really afraid that X, Y, or Z, and there's nothing else to tell you that they would do that thing, not a report. They're not telling you they're going to do it. There's nothing to suggest they're going to do it. And you can run through scenarios with them of them doing the thing. And that also can give you information about like, okay, so which is which. It takes a lot of assessment skill. If somebody's like, yeah, I did hurt my child, or I did do this, or I did touch a child inappropriately. Okay, well, now you have a very different thing on your hands. And yes, you have a lot of mandated reporting to do, versus somebody saying, I'm afraid I might do X, Y, or Z. Also, if somebody's coming to you and saying, I'm afraid I might do X, Y, or Z, the fact that they're coming to you and talking about it is also a really good sign that they're probably not going to do it. Yeah, so I get to IFS in a little bit, actually. Yes, ruminations, intrusions, what's going on? All right, so we're going to talk a little bit about suicide, and then we're going to take our break. So, what we know about suicide. Suicide is the 11th leading cause of death in the US, second leading cause of death in individuals between the ages of 10 and 34. Men are more likely to attempt suicide, where women are more likely to self-harm and have ideations. There are nearly 2 times as many suicides in the United States as there were homicides in that year, which was 22-23. Attempts versus deaths, the number of non-fatal suicide attempts is estimated to be 10 to 20 times higher than the number of suicide deaths. Childhood trauma, attachment trauma are considered significant indicators of suicidal ideation. Firearms are also the leading method of suicide for both men and women. We always talk about how like women are more likely to overdose, and like, yes, women are more likely to use overdose as a means. The thing about firearms is that they're incredibly lethal. And so hence why firearms are the number one cause or number one method for completing a suicide. They're just more lethal. This is just a fun little chart that I pulled off of the CDC. So it shows you where like suicide ranks. I thought that's not right. Okay. I think that it's really interesting that it was second for 10 to 14-year-olds. A lot of times I think we look at suicide as a older teen problem. Clearly it is not. I mean, it is, but it's a problem across the board. And then also for 25 to 34-year-olds. Just, I think it's interesting. I think our research on suicide in the US is very interesting, and I think we need so much more information. Again, this is from 2022. It takes them a long time to get the numbers out. Considering this is from the CDC, we may never get another chart like this. Suicide treatment. Assessment is critical. there are so many options for assessing suicide. So you have the Columbia scale, which is like one of the most common. People use all sorts of different depression scales. They have usually suicidal ideation listed on them. There's a lot of them on like the dissociative scales as well, like a lot of questions about it on dissociation scales as well. But these are our main suicide treatments. These are the ones that, these 6 are the ones I'm going to go through. Obviously, there are more, but we're going to go through these guys. So, cognitive behavioral therapy for suicide prevention. It's very time limited. It is very targeting. Like we are targeting the suicidal thought. So I'm sure you can see like chain of analysis of suicidal crises really plays along well with ICBT, and how in ICBT we create a map of how the obsessional doubts become thoughts and faulty reasoning and all of that. Safety planning and coping strategies, always, please, always. Modifying hopelessness and maladaptive beliefs sometimes doesn't work for everybody. Problem solving and support, relapse prevention skills are safety planning and coping strategies. It's exactly what you think it would be if you're treating suicide with CBT. Nothing exciting. I mean, it is important and all of that, but it's pretty self-explanatory. DBT is also time limited. It is very structured. True DBT means you cannot work with another provider while you're doing DBT therapy. You are in individual therapy and you are in group. Chronic suicidal ideation and self-harm. It has its trifecta, more or less, of emotion regulation, distress tolerance, distress tolerance, and interpersonal effectiveness. And I actually pull from their emotion regulation and distress tolerance regularly, just because I always have a handout because it's DBT. And so they're really easy to, they're an easy way to like have someone take something home with them, that gives them like an outline of how to do this thing. Especially if you have someone who is feeling very overwhelmed, and when it hits and they can't actually get through to anything, having something there that can like tell them what to do can be incredibly helpful. Coaching and crisis management. You are supposed to have a phone coach when you are in DBT. And so hopefully that person is also helping you work through like the crisis of the moment. And then reduces behaviors through behavioral analysis and commitment strategies. So there is a lot of, in the same way with the CBT and some other things, there's a lot of mapping of like, okay, this happens and this happens and this happens and this happens. Now we flip our lid and this is how the come down is. This is where I hurt myself. This is where this happens. Lots of mapping. Generally speaking, lots of mapping in suicide treatment. Safety planning, brief, collaborative. There are more than, I don't even know how many options you have. Like you can type into Google, like safety planning for teenagers, safety planning for 21-year-olds, and you will probably find something. One of the things that I think is really important is a lot of times we make a safety plan, we hand it over, and we say, all right, we have our safety plan. It includes means of safety planning. So within, like, obviously you might not have everything in your office, or anything like that, but we list out on our safety plans, like what to do, like, go for a run. Okay, wear your running shoes, wear your socks, where's your reflective gear or whatever. But like being very, very clear about the means of what we're going to use in our safety for our safety. And so, I mean, there's a lot of different ways to do safety planning. I think one of the most important things about it is just making sure that it can be utilized, that it is usable. Obviously, you can't make your clients do anything, but that it's usable, and these are specific things that they can do to make their safety plan more effective. So. Attachment-based family therapy, more family focused, obviously, repairs attachment ruptures, improves communication, increases caregiver responsiveness. And I think one of the things that goes with this particularly is increasing the emotional safety. And so looking back at like the OCD treatment, that emotional safety and the caregiver responsiveness is really important when particularly working with kids. But keeping in mind that responsiveness does not mean accommodating. Those are not the same thing. And strengthens protective family bonds. Obviously, this is not appropriate for many people. One, because they may not have a family. Two, their family may be the source of their trauma. I mean, so many reasons. Fill in the blank. Checking my time. All right. Internal family systems. Identifies suicidal thoughts as parts, carrying extreme burdens. Builds self-leadership and internal compassion. Reduces internal polarization and shame. And processes trauma underlying the suicidal parts. So I think one of the things that's important is, like, generally speaking, it's not just like one part is the suicidal part. If we're looking at trauma, we probably have multiple parts who have some suicidal ideation. And so getting to know those parts and like what is triggered and when and how to use the parts work. They refer to it as unburdening, but using the parts work to flesh out where some of these things come through and why suicide becomes the answer. Grief and trauma modalities, complicated grief treatment. That's out of Columbia University. It's very CBT based and how they structured it. Really good stuff though. I really liked it. And then EMDR and they have actually started a protocol for EMDR for OCD, which I have not been trained in yet. It's on my list. But EMDR can be incredibly helpful for suicidality. So also very important, I know we kind of had a tangent earlier. Same thing. Suicidal obsession refers to the OCD obsession or rumination and is accompanied by great fear of completing a suicide. People experiencing suicidal obsession will avoid whatever method they are trying to ruminate. I had a kid who I saw who was sure he was going to kill himself by flinging himself down the stairs. He literally would not go to his bedroom, which was upstairs. He slept on the couch for like 2.5 months because he was sure he was going to fling himself down these stairs. He did not. Then he was also afraid he was going to jump off a bridge, and he lived in DC, and so to go anywhere you pretty much have to cross bridges, and so that also became problematic. So one thing, suicidal ideation is the thought patterns that and planning. Thought patterns and planning, and there's the plan is the important part. It's when they decide they're going to end their life. In the case of OCD, it may seem like the only option to stop those intrusive thoughts, to stop the body responses, etc. So this is another thing that I think is really important, because if it is suicidal obsession, if it is suicide OCD, and you hospitalize someone, you have more or less just reinforced that their obsession is accurate because you believe they're going to hurt themselves too. However, again, this is where assessment is really crucial. If there's an actual plan, if the person is saying, this is what I'm going to do, please, by all means, do whatever you need to do to get that person safe. Usually though, I think this one's a lot easier to distinguish than some of the other things, because you will find that people with a suicidal obsession are incredibly terrified of it and do things like refuse to go upstairs because they're afraid they'll kill themselves. Or like they'll take all the knives in the house and make somebody hide them because they're sure they're going to cut themselves. Okay, that's very different than hiding the knives from someone who is actively cutting. In fact, the best thing you can do for that is take all of the knives and lay them out on the counter and leave them there. Because the more they walk past that and the more that they experience that and nothing happens, the stronger their resolve more or less becomes that it's going to be okay. Like they're not going to do that thing. Again, sounds really counterintuitive. That's what they say to do. So again, very different than self-harming, very different than suicidal ideation. What we know about attachment theory. I'm not going to go too deeply into attachment theory because one, I'm assuming most of you are familiar, but two, that is a very, 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 very deep hole. So it was developed by Bowlby, insecure and secure attachment, enhanced by Ainsworth, insecure, anxious, and avoidant. And then Main and Solomon came up with disorganized attachment. So attachment anxiety excessively looks for help and creates a need for someone else to be the caretaker. I really like this particular researcher, Gormley. She's very good. Attachment avoidance is excessively self-reliant and will not allow anyone else to take on a caretaking role in their life. High levels of attachment anxiety and avoidance coexist, resulting in conflicted and ineffective response, and a breakdown in organization results in odd responses, such as dissociation. Can other people hear me?
Yes, we're able to hear you. If anyone wants to give a thumbs up, yeah, awesome.
Great, perfect. Thank you so much. So attachment trauma and the development of CPTSD. Attachment trauma is an ongoing traumatic experience. Think of it as like there's not an end. Usually is a childhood situation. However, there are other times when it pops up. And we can't say definitively attachment trauma leads to CPTSD. We can say that attachment trauma is commonly endorsed by those who have a CPTSD diagnosis. Also, CPTSD is not a diagnosis in the DSM. It is in the ICD, not in the DSM, because apparently they can't get it together. I don't know. Anyway, all right. This is one of my favorite quotes of all time. From an attachment theoretical perspective, suicide attempts by adults are protests against the experience of not existing in anyone else's mind, an experience of profound loss and complete abandonment. Um, I, it's just so well put. I found this quote early in my research, and um, it became a reason for me to keep going when I was very upset about what I was studying or just annoyed because I was tired. But it it became a reason. The idea of profound loss and complete abandonment in anyone else's mind, not feeling important to anyone else. I feel like she just captures the experience so well. Um, I highly recommend reading the things that she has written. She's great. Um, Attachment and suicidality. So there's actually been a good amount of studies on this. 52 studies regarding the relationship. It validated the role of insecure attachments in suicidal thoughts and behaviors. I'm sure that's not shocking to anyone. Secure attachments are considered to have protective roles against suicide. Also not a shock. And there were no notable differences between suicidality and one type of attachment insecurity. Both avoidant and anxious attachments create equal risk for suicidal thoughts and behaviors. So one who is secure also usually has an appropriate sense of self. They're able to manage their own emotional states, or they have people around them who can help them manage their own emotional states. Everything that I read on attachment and suicidality, I was like, figured, sure. Risks and warning signs: suicidal thoughts after rejection, conflict, fear of abandonment and mood swings, shame, self-blame, and disorganized attachment, self-harm or dissociation, limited support, and suicidal during breakups, transitions. As you'll notice, a lot of stuff around changes. When changes are happening, if there has been rejection, if there has been a shift in relationship in particular, very important time to assess for suicide. The fear of abandonment can be tricky, particularly when we're looking at an avoidant attachment and somebody who's like, I don't need anybody, and yet they are very afraid of abandonment, but it's hard to have those conversations and sometimes hard to assess that. So, attachment and OCD just got very close together. OCD beliefs are centered around anxiety and avoidance of the anxiety. Researchers found that attachment anxiety and avoidance are linked to similar faulty inference, back to inference of CBT, in inference processes in cognitive models of OCD. So both avoidance and anxiety are believed to be hypervigilant response to the exposure or fear object without a secure space to reground. So we're looking more at like the ICBT model of like the faulty reasoning and also like the experience of abandonment. There are some places and some studies that talk about the development of OCD as a way to control your environment when you were a child and you were experiencing attachment trauma. There's also studies that talk about development of OCD as a means of making sure you're good enough for your parent, or a means of or a way to avoid any form of harm from your parent. If I do X, Y, and Z, then I won't get hit or whatever. And can become a very obsessional thing. Because there's no secure base to reground somebody when we have OCD and attachment, a lot of times, just like in the case of treating trauma, the therapist becomes like that first experience of that before hopefully building that up outside of therapy. But the therapist usually is the first experience of having that regrounding, like having the ability to reground with someone, and that co-regulation. Co-regulation is very important, and it is also usually not present when we're looking at attachment trauma. So one of the things that I found in some of the research, it said that individuals with anxious attachments are prone to exaggerate the threat, while those with avoidant attachment tend to overemphasize the importance of their own thoughts. Difficulties in affect regulation in response to distressing or intrusive thoughts increase the possibilities that these intrusions escalate into persistent obsessions. I thought that was really fascinating. I also think it's fascinating that just attachment insecurity, generally speaking, is a has, it doesn't matter what kind of insecurity, attachment insecurity we're talking about, it has the same, like the same threat exists as far as the development of OCD. I when I do this talk in academic circles, one of the things I usually just say is insecure attachment bad, secure attachment good, and that goes like across the board. Like that's what we're talking about. The secure attachment in most cases can heal a multitude of issues. So of course, when I give this talk in academic spaces, they want me to then cite a reference for saying that. Attachment and OCD, more individuals with anxious attachment are prone to exaggeration of threat. Oh, I said this, or the importance of their thoughts. Those who have been diagnosed report with OCD often report attachment insecurities or rupture during their developmental years, especially that 82% of treatment-resistant OCD. That is where we find a lot of that explanation. Ooh. OCD and suicide. Individuals with OCD exhibit significantly higher rates of suicidal ideation and attempts compared to the general population. A systematic review analyzed 63 studies from clinical and epidemiological settings. It reported elevated rates of suicidal ideation and lifetime suicide attempts among individuals with OCD. So for a very, very long time, up until like pretty much the last like 10 years, maybe even less, OCD was thought to have relatively low rates of suicide, because when suicide came up, people automatically assumed that it was the suicidal obsession versus ideation, or people who had high or strong suicidal ideation in regards to their OCD didn't report it, didn't talk to their therapist or whoever about it if they were even in therapy. There's also, of course, a correlation between OCD and the type of OCD obsession and suicide. So, you know, talking about pedophilic OCD and somebody's feeling incredibly distressed, doesn't want to talk to a therapist about it, makes sense. So what they have found, though, is significantly higher rates of suicidal ideation and attempts The study that did this identified critical risk factors with suicide risk and OCD diagnosis, lower educational attainment, unemployment, the presence of comorbid mental health disorders, such as depression and generalized anxiety disorder. The other study said OCD severity, intrusive, unacceptable thoughts, and then again, comorbid anxiety or mood disorders and emotional factors. Additionally, childhood trauma and family history of suicide emerge as significant factors in prediction of suicide amongst those diagnosed with OCD. So we believed one thing for a very long time. That thing is not true. In fact, it's quite the opposite. And so, one of the things that this has changed for me is automatically if somebody is coming to me for OCD, I am doing suicide assessments, just seeing where we're at. Obviously, you're not going to catch everything every time because people, as we know, do not always tell you. However, I that has become a big part of my personal practice. And when I've talked to other people, it's not necessarily a part of their practice. They kind of just assess as things go. But I like to start having a baseline, if at all possible. Key risk factors, we already went over these. The unacceptable thoughts is very important, and the severity of the OCD. If the OCD is leading to like full-blown agoraphobia or inability to connect with anybody, inability to talk to anybody, then yeah, we're also going to have higher rates of suicide. Loneliness is a horrific thing, particularly when you have OCD. Trauma and OCD. Oh. So I think I have already told you this. 82% of those with primary OCD diagnosis who were identified as treatment resistant reported a history of trauma. Makes sense. The presence of comorbid PTSD was found to impede OCD treatment response in intensive residential settings for those with treatment refractory OCD resistant. The relationship between OCD and trauma is understudied and underidentified. I mean, 30 and 82% was what another study said, have a traumatic history. So this is my dissertation, is on complex trauma and OCD. There is so little out there. I was doing research and I found exactly one article that talked about CPTSD specifically, and OCD. There are a few articles, not that many, but a few that talk about trauma and OCD. Again, looking more at the single incident OCD or trauma and OCD factors. And there's some about like certain types of trauma from veterans and OCD factors. There was a study out of the VA that said within 1 year of a PTSD diagnosis, over 30% of veterans qualified for an OCD diagnosis, along with the PTSD. We know it's a thing. It is a thing. I will be writing on it more, and hopefully more people will also get interested and write about it because it's a very big deal. And right now, the trauma and OCD work that we have, a lot of it is coming from like starting with the OCD as the start point versus starting with trauma as the start point, in terms of like when somebody is showing up for therapy. Like they get to the trauma most of the time, in my experiences, I get to the OCD. Trauma is what brings people in the door. Trauma and attachments. Again, I don't think this is groundbreaking for anybody. Children who endure interpersonal trauma or persistent adversity are more likely to develop insecure or disorganized attachment patterns. Those are some of the factors. Obviously, there are many. And those difficulties may, in fact, include both OCD and suicidality. This is a fun little chart that I made a while ago, but it just shows the, like, if we're looking at trauma as our starting point, if we're looking at trauma as our starting point, and then looking at these three things and how they come together, and we get the maladaptive emotion regulation. Okay. Before we jump into case example, discussion. So feel free to throw your answers in the chat. I'm guessing that's the easiest way. Any one of the questions, feel free to answer. If you want to put the number of the question beside whatever your answer is, so it's easier to know what we're talking about, great. The discussion questions are: think about a complex case you've worked with. How might attachment patterns have been influencing symptom severity or suicidal distress in ways that weren't immediately visible? When you hear a client with OCD express suicidal thoughts, what questions or clinical instincts arise? Again, first for you as a clinician, what challenges have you encountered in balancing client autonomy with safety planning? And so we've talked about some of these things already, but I am curious from a clinical standpoint, yes, but I'm curious more about, as clinicians, how you as a person respond in some of these things. We are people, and we do not get it right every time. And we all have our own things and our own reactions. Heart races, but assess for a plan. Yeah. Are they thinking about it, planning, have lethal means, contract for safety? Yeah, the more the client discussed her family of origin, the more trauma surfaced that she didn't identify as trauma, and she thought it as normal. I think that happens all the time. The number of times people say, like, specifically, like, but that wasn't trauma, right? And I, like, internally am like mouth agape, is just ridiculous. I'm regularly astonished by the things people were like, but that's not trauma. I don't know what that is. Losing trust because we prioritize risk safety over autonomy. Very real, very, very real. And I think, I mean, I have definitely had to repair after that in my career more than once, where I panicked and then had to go back and really, really repair the relationship. Yeah, dealing with minors and they're already told what to do. I love that. Trying to find ways to give kids as much autonomy as possible. Challenging. And I think is also just incredibly important. Social supports. Working in a school setting, my first instinct is to assess for safety, but being in a school also means we typically get another agency involved to assess and safety plan further. Great. Terminal patient in hospice, very real. When discussing safety planning and suicidality, challenges I have dealt with have been related to a minor client who was mandated with a helicopter parent who was not receptive to collaboration and had a controlling parenting style. I believe in client autonomy, but having a non-cooperative parent who antagonizes the child makes it difficult. Oh yes, it does. I mean, I think that that's the parental response in any of these, but particularly parental response when it comes to anything involving suicide is deeply important and can also be one of the most frustrating things of all time. Planning. I had a client who told her mom that she wanted to swallow a bottle of Tylenol and die. And her mom said, well, you were just trying to get your way because you know that that will tear your stomach up and not kill you. Quite the response. All right. Assess the intensity of the obsessive thoughts. Is there a plan? Unsafe. It's harder when a client does not want anyone to know what's going on. I have always tried to encourage them to have someone they can reach out to. When I explain that it doesn't have to be a family, it seems to help. Agreed. And this is a very common thing too with OCD. People don't want to tell, like people don't want anybody to know what kind of thoughts they're having. They don't want to talk about it. You know, view the client holistically, ensure suicidal comment was taken seriously, and support the adult client to receive assessment and inpatient care. Coming from trauma, I'm very validating. And then, like stated above, assess for ideation or plan. Several feel alone and recognize that they aren't. Ask more, listen as much as possible. Yes, that is exactly it. SI is egosyntonic or ego dystonic. That's also a great way of putting like the suicidal ideation versus the suicidal obsession. Dealing with child dealing with mother's immigration status and birth of brothers and sisters developed OCD and deals with it 25 years later in the form of scrupulosity. Makes sense. Second opinion, assess for safety, build trust. No trauma Olympics. There are no trauma Olympics. Right. I love this. I could go through this for a very long time. All right. So any questions? Anything anybody would like to ask before we jump into our case? I know Bonnie also put it in when we all came back, but just a reminder, the case example does involve a lot of sexual trauma and suicidality and OCD. But if that is triggering, if you need to take a step back, just let Bonnie know and we'll figure it out. So, right. Case study. I deeply love this. I deeply love this client. And she has signed off. Well, it's a composite. So the people involved have signed off on this. So name is May, 30 years old. She is biracial, German and Cuban. She's the middle daughter of three girls. Her parents have been married or are married, but have been together for 37 years. Her oldest sister is married. She, her husband, and three children all live in the family home. She is divorced, but currently dating someone who is non-binary. May was born in the US, but spent the first 10 years of her life in Germany. So she was married to an Irish international. They started dating when she was 22 and got married in 2021-ish. And she caught him cheating on her. And so and there was a lot of financial abuse as well. So they got a divorce. Um, her attachment ruptures are many. When this is the first part of her trauma timeline, when she was very little, her grandmother was verbally abusive and emotionally abusive and physically at times. Her grandfather was her main person protector, but he was sexually abusing her starting very young, and was sexually abusing her. Um, would he would shower with her, and her mom told her that it was normal. When she tried to bring it up to a therapist later, the therapist told her it was just a cultural difference. There have been a lot of work that we've had to do around that. And her mother also started abusing her when they were living in Germany. Her mom was very, very impacted by the grandmother, and joined in. Um, she was also sexually assaulted by her cousin, who was a little bit younger than her first boyfriend. Um, and then she has experienced a lot of medical abuse by her mother and lost her best friend to suicide. And then her brother-in-law has been another attachment rupture. So, starting from an early age, she learned that she had to more or less sacrifice her body to be taken care of. The only person who would stand up for her was her grandfather. The only person who would take care of her in any way was her grandfather. Her dad was in the US for most of the time. And she didn't really have a relationship with him until they moved back over here. Um, when she was a young teen, her mom started taking her to eating disorder clinics and telling everybody that she had anorexia. Um, at the time, she did not, but she developed anorexia, and almost died from that more than once. Um, Anytime she would go to family therapy, which started in her high school years, she also started cutting at the age of 6, um, while she was being uh, abused by her grandfather. Um, but her mother would hijack her therapy and her therapists, on four different occasions. Therapists would terminate work with her to work with her mother instead. Um, so she has a lot of deep mistrust when it comes to any sort of mental health care, which makes sense. And she experienced drug use in her late teens, early 20s. And her first love died by suicide 3 months after he got married. Um, we'll get to. There's a lot of stuff on the screen. There's a lot of stuff going on. She has been through the ringer. Um, and while this is a composite case study, the uh, the traumas are consistent with one person, if that makes sense. Details of the traumas may be changed. But this is not, oh, I took multiple people and gave them all the trauma and put them into one person. No. So she was in and out of residential treatment through high school. She first attempted suicide at the age of 15. And then again at the age of 16, she attempted again, but she says the one at 15 was her first real attempt, because she would like intentionally try to cut too deep or take more medicine than she should before that. But at the age of 15, she overdosed and was in a coma for over a week. Yes, she also was abused by in a long-term relationship, and ended up needing a protection order against him. More trauma. Multiple suicide attempts throughout young adulthood. She was in residential. She was sexually harassed and given the means to complete suicide by one of the providers at the residential. That person was, of course, fired and lost their license. And she, like, that also leads to her not wanting to open up to people. I've been with her for 5 years now, and after a year, she was like, "You're the longest I've ever had the same therapist." Like, wow, that might be part of the problem. Her ex-husband was emotionally and financially abusive. She was diagnosed with a brain lesion causing migraines when she was 29, so about a year ago exactly. And then the same night she actually got her diagnosis, she went out with her brother-in-law, who has been around forever and has been, again, like a protector for her and someone she's very close to. He started dating her sister when she was like 13 or 14, and her sister was 16, 17. So he's been around for a very long time. And that night, he sexually assaulted her, which created quite the ripple effect when it comes to her healing and some undoings. Again, and I think, one of the things we talked about many times is the piece around the people who she believes were there to protect her, then abusing her, like her grandfather, her mother, her brother-in-law. All of those people were supposed to be there, felt like protectors, but she firmly believed that she had to give something of herself in order to be cared for, loved. She still believes this. We're working on it. So these are just when I first started working with her and then throughout our time together. She's completed the following assessments, which are listed on the bottom. She is now diagnosed with DID, which that was also a very long diagnostic journey. She mainly presents with harm OCD. She's terrified she's going to hurt someone. Somebody told her back in the day that hurt people hurt people. And so now she's terrified that she's going to hurt somebody because she's hurt. Working on that. Being taken care of has always meant she must abandon herself. And in my care, she's had at least 4 suicide attempts. And they've been scary and hard and terrifying, and I have hated every moment of it. So generally speaking, I would follow Judith Herman probably into a burning building. So this person has been both in person and telehealth. And go back and forth depending on her ability to get from point A to B. I tend to stick with a triphasic model, which if we go back and talk about all of the different models that we talked about via OCD, suicide, and attachment theory, a lot of them follow a similar idea. Safety and stabilization, that CBT, we're getting our coping strategies. We're working on distress tolerance, etc. Remembrance and mourning, processing the traumatic memories. ERP, that's where you're doing your exposure and response prevention. Or ICBT, that's where you're doing your mapping of the faulty reasoning, etc. So they play together well. The models can play together well. They can also not play together well, but they can't. And then reconnection and integration, rebuilding and creating a new future. Somewhere between phases 1 and 2, the OCD started to emerge. And whew, so our treatment has been a mix of skills from many different treatments, many of the ones that we have discussed earlier. Again, this was like a, what do I do? And nobody could tell me. And so I was more or less educatedly making it up as I went along. And there were things that did not work for her. I tried some EMDR. I didn't do the eye movement because of her dissociative levels, but I used some things from EMDR that did not go well. I used some things from ICBT that worked amazing. I used some other things from that did not go well. And so because of with OCD, most of the time people want to be like, here's your formula. And I think with suicidality, a lot of times people want to be like, here's your formula because we don't want to get sued. And then you have trauma and people are like, well, here's your formula. And then anyone who's ever worked with trauma is like, so like, now what? And so I think that trying to mesh and merge some of these models was interesting that way. Because at some point in time, when those OCD symptoms started to emerge, there were a few that we actually had to deal with before we could continue working on some other stuff because they were directly related to therapy. There was one that was like very, very, I mean, they were all very safety related, but there was one that where she wouldn't leave her house and she got very, very insular, which then, and at the time she lived with her family, and then that led to just a constant parade of traumatic memories and more trauma. And so we had to get her out of the house before we could work on any of the other things because she was constantly in a state of re-traumatization. So that also added a level of complications. Yes. Once OCD became clinically clear, we looked at what would be appropriate and doable, right? We can get her out of her house. However, like, I'm not going to have her, go tell off her brother-in-law tomorrow because that would be a trauma exposure and it would be way too far. But getting her out of her house was also like a process. And she was sure that if she left, someone in the house was going to die. Like she knew it was completely illogical, but she was like, if I leave, then like my sister's gonna die. It did not happen. Nobody died. But it took a lot of work. It took a lot of work to get her out of the house because there was this belief that like somehow she was responsible and somehow she could save her sister if she was there. And even though her sister was fine, it felt so real to her. And this is where we used a lot of the faulty reasoning and broke it down as to like where some of these thoughts had come from, why she was feeling this way, what was happening underneath the surface. And so like we were able to break that down and get her to leave. But the appropriateness and that being doable is absolutely critical because if somebody, and I think that this is another, I don't think I know, this is another area where trauma and OCD don't necessarily play well together. Because if you have someone coming in for OCD and you don't know anything about their trauma history, and then you're doing an exposure hierarchy and they're like, yeah, because maybe they're halfway dissociative. And then you're like, okay, here's your exposure. And then now like they can't do it, or it's way too overwhelming, or it triggers suicidality, or the list goes on. And so I think this is also an area where it's just incredibly important to keep the assessment lines open always. This is also an area of reduced reassurance seeking. As trauma therapists, we're incredibly validating. We validate and we care, and we do reassure in so many circumstances where it is completely appropriate for us to be reassuring. And so one of the things that's really difficult is when you as the clinician have to differentiate between, is this OCD reassurance seeking or is this appropriate trauma need for reassurance? And I'm not gonna lie, I have gotten that one wrong. It has happened both directions. And so I think that that also just takes, like, it takes some time, and it takes really knowing your client. Usually when the what ifs start to come in, that's when I'm like, oh, this is OCD. This is the reassurance seeking part of OCD. What if this? What if that? What if this? What if that? Probably OCD. Utilizing different parts of OCD, we were able to target specific traumas, make sure of some EMDR, narrative therapy, and cognitive processing therapy. Cognitive processing therapy is also very CBT based in a lot of ways. And so that was, again, we're bringing all of these things together. And the Venn diagram of the treatment modalities are quite on top of each other. Yes. Okay. Any tips on how to cope with a client that you think you were making progress with and then they attempt suicide? Breathe. 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 I think that, I mean, unless you are a sociopath yourself, when a client attempts suicide, no matter where you are in treatment with them, it is just incredibly disarming and alarming and painful, incredibly painful. One of the things that a supervisor said to me was, you have to remember that it's their decision. And if you are making great progress in therapy in so many ways, the suicide attempt might actually be a testament to how much work you have done, because you've been able to uncover so many pieces of the puzzle. You have been able to be a safe place. And then something happened or something triggered something, and now that person has attempted. I don't know if there's anything quite scarier professionally, for me. Anytime that this client has attempted suicide, I mean, I have needed time. I have needed to take some time, breathe, go for a run, jump in some cold water, like reset my own nervous system. And one point in time, I literally took a day off of work and laid on the couch and cried because it was a really bad one. And I was very, very scared. And this client is very treatment savvy. So she's very good. And I've now learned this. That was midway, probably a year or so ago. I've learned this, but she's very savvy at hiding what she's actually feeling. And we're not going to catch it every time. That is the other thing, is like, we are not all knowing. Also, the last time we saw a client, everything could be great. They could actually be doing really well. And something happened on their way home from therapy, and now they've made a decision to do something. I always talk to my clients about the safety piece, and like, okay, you agreed to therapy with me, so like, you're expecting me to be here and show up. I'm expecting you to be alive. And this is also highly debated in the treatment community, I'm pretty open about how those experiences impacted me appropriately. Like, I'm not going to tell her, like, I laid on my couch and cried for a day. But I have told this client, like, I cried. I was scared. I I didn't know what had happened to you. Um, and so there's debate as to whether or not that's uh appropriate to do. But I think especially when we're talking about attachment, it's also showing our clients that, like, we're attached to them too. Um, and I think that that's important for them to know. Again, right? Like, I'm not advocating crossing boundaries or, turning it into your therapy session. um, but I think being able to use some of your own emotion and co-regulate in those moments can be really therapeutic. I had a client one time who attempted suicide, and when they finally came back, we were having a conversation, and she said, well, nobody cares. And I was like, what do you mean? She's like, well, nobody cares what happens to me. Like, nobody cares. And she really believed that nobody cared. And when I was like, well, I care, and she was like, well, why do you care? And we had a whole conversation about it. But it is incredibly hard. And the number one thing I can say is find ways to recenter yourself, reset your own nervous system, find a friend, take a shot of whiskey if that's your thing. Whatever you need to do to take care of you, do that. Yes, we have had many setbacks. I have said the wrong thing more than once. Um, I Our setbacks have ranged from uh me challenging her on certain things that she did not want to be challenged on, to discussing her trauma and me pointing out that something was trauma. Um, but yes, there's a lot of setbacks. And I think we always kind of go back to stage one, that safety and stabilization. We're always going back there, through therapy, especially in these things. Yes, when we're saying we, me and the client. Nobody wants to work alongside me because they don't like my cases. um, they don't they don't like they don't like the people I work with. Um, yes, so her sister does know about the abuse by the brother-in-law, and she told her she was a slut and she should have kept her legs together. So went real well. The younger sister doesn't know anything about it. The older sister also knows about the abuse by the grandfather. Relapse is normal. Yes. So well put. Relapse is normal. Um, do not blame yourself. Um, Compassion, be compassionate. Having a supervisor, therapist. I'm a very, very firm believer of having a therapist as a therapist, especially if you are doing this kind of work. If you are working with people who are unstable, if you are working with people where, like, you walk out of the room and you're like, I just heard the worst thing I've ever heard in my entire life, have someone to talk to. Um, Supervision is great. I love supervision. I love being supervised. I love doing supervision. I think it's great. We do need our space. Um, yeah, so the piece of parents knowing about it but refusing to acknowledge it, I firmly believe that her mother knew what was going on with her grandfather. I think her mother was probably his first victim, based on some things, and I've met her mother. But her mom would never admit that under any circumstances. Level of impulse control. Well, two things. One, if we are working with somebody who has multiple different parts, know what part you're talking about. If you're talking to somebody who has DID, so multiple different parts, know which part you're talking to when assessing for impulse control. A 12-year-old is going to be more impulsive than a 30-year-old. Every time she has attempted suicide since the age of 15, she always tells me that she felt like she was 15 when she did it. And once she like went through the dissociative experiences scale and had done an inpatient round, like in the DID came to light, it was very like she was like, oh, like that makes so much sense. Like that was a different part of me. It always felt like a different part of me. So we've done some very specific things around like that 15-year-old part and around building up those coping strategies and really building up that the impulse control. History is your best indicator of impulse control. Have they been able to do it before? Do they have a history of running out and doing things? Look at their history. Healthy attachment responses. Yes. Yeah, so talking about the resentment towards her family, yeah. One of the things that I have talked about so many times with this client is getting angry. Because in her view, getting angry, that was like a recipe for disaster. You weren't allowed to get angry. Getting angry meant you were a bad person. Um, and so she's mad. She's angry at her family. And she was like, I shouldn't be angry. Anger is bad. I shouldn't be angry at that. And I was like, I'm angry at them. Like, of course you're angry. Like, are you going to stay angry forever? Probably not. No, but you're allowed to be angry that you were treated this way. You're allowed to be angry that your dad flat out told you he would rather you uh, break off all contact with them instead of talking to your brother-in-law about what he did. Like, you're allowed to be mad about that. These are things you're allowed to be angry about. Um, but it takes some time. And the resentment can feel really, really horrible and can make you feel really alone. And it's all an important part of the process. Yeah. The mother, I have met the mother, special. She's a special, special character. Um, for DID, it's honestly, assessing what part we have and then going for age appropriate interventions for that part. So when her 15-year-old part is forward, when that is the identity or however you want to put it is forward, we work as though she's a 15-year-old. The work I do with her is much more teenage based. That's where we are because that's where she is in that moment. And so trying to reason with her in a 30-year-old way isn't necessarily going to work. So I go back to like CBT, thought action, differentiation, but all in like a very like 15-year-old way. I mean, the same thing is true when like I have another client who has DID. One of her parts is 5. When that part comes forward, I treat that part like it's 5 because it's 5. She's 5. And so I'm not going to get anywhere trying to treat that part like she's 60. That woman is 60. So it gets tricky. DID is super tricky. And it is so honestly understudied, but that's a different. It depends on confronting the abuser as to who the abuser is and how strong the person in front of you is. So I have had people confront their abusers, but usually I recommend controlled environment if at all possible. And like that is a thing that we process through so much. And sometimes it is not worth it. Like it is not worth it to them. And I say, I think that that's a fair thing. Like I think it's okay for somebody to be like, I don't want to do it. That's their choice. Totally their choice. So there are some people that I think would benefit greatly from it. There are other people who have done it and done it somewhat impulsively. And I've been like, oh, now we are dealing with suicide. So really depends. Yes, there was a family session early on when she was highly suicidal. This was really like very early in my work with her. And then again, after another suicide attempt while she was still living at home, I had a conversation with her mom during that time. But because of knowing her history with her mom in therapy, I was very, very careful about those conversations, and very, very guarded. And the client and I had extensive conversation before any of that happened. Like at the time, that was her safety plan. Like her mom was her person to call and back up. That has changed. So that's at the time it was appropriate because that's who she was identifying. Now it would be illegal. We talk to her mother. So um trying to think. For her, it took about a year, no, like 2.5 years, I would say, for us to fully get to the DID diagnosis. I had suspected it for a really long time, and I had had her do the mid-60 and the dissociative experiences things, and they were off the charts. And then slowly but surely, these things made their way. Oh. I think it's about the same. Usually the ones who schedule are the ones is the one who is like the most present, or like their true self, or depending on who you ask, whatever they call it. Um, Sometimes you might get a phone call from a younger part, but um, I've only had that happen, I think, twice. Usually those parts aren't coming to you necessarily. Um, but yeah, I mean, I think it's a similar boundaries thing, and sometimes you have to have the conversation with that part about boundaries, but it's very similar. Yes, I am still seeing her. Um, she's we're still here. We're still doing it. Um, okay, yes. So she's been in treatment since adolescence. She's been diagnosed with everything under the sun. Um, she could never get the treatment she needed because people didn't know what they were looking at, one, or they were taken from they were hearing it from other places. What was happening, like i.e. her mom or her dad. Actually not her dad. Her dad was not involved. He's the most avoidant person I think I've ever encountered in my entire life. So objectively though, CPTSD and OCD can mimic each other, making differentiation really challenging because we have and also hindered more research because there's a ton of safety related behaviors in OCD. And there's also a ton of dissociation in OCD, which is another whole thing that could be a training in and of itself. And a lot of over fawning. There's a lot of control, and all of these things, play together and create a very, very convoluted diagnostic picture. And it's not, I wish I could be like, and then you do X, Y, and Z, and now you're good. It is so much assessing, so much assessing. And it's also like incredibly important to know to know your options, I guess is how I would put it. Particularly when we're looking at someone who's been in treatment for a really long time, what has been tried, what has worked, what hasn't worked. May went through 4 different rounds of DBT. She completed DBT 4 times. Did not go well, right? Like she got the skills, but nobody had touched the trauma. So the skills were honestly kind of useless in that way until we figured out how to relate them back to her trauma and how to utilize them in triggered situations. And that like really contributed to the suicidality because nobody had touched the trauma. So now she's over here saying like this one thing that I am told fixes suicide didn't work for me. So therefore I am broken. Therefore I'm going to kill myself. Very problematic. And so noting those things, important. How did they not do that? I ask myself that question every day. I agree. If there's DBT, if you need DBT treatment, most of the time there's trauma. Most of the time, people are not just in that space for no reason. A lot of times there's trauma. I used to do DBT with kids, and we used to always say in our practice, kids who need DBT have parents who really need DBT. And I stand by that because there's so much trauma and there's so much that is like intergenerational, rolling downhill. Not a great time. So yeah, I am constantly amazed at the lack of assessment abilities in the world. Just boggles my mind sometimes. So, it's fine. Yeah, so this is very important, right? Like looking at what has worked, what hasn't worked, what has made somebody feel seen, what has made somebody feel degraded, unimportant, all of those things. The other thing too is I know people really want to get through it. Like people want to process the trauma. They want to get done. They want to have the OCD done. This is not a quick treatment process. Like I said, I've been with this client for 5-6 years. I have another client who's very similar who I've been with for 11. She's not going anywhere anytime soon. And as much as I wish I could say like, hey, look at this, we can do this or we can do that. And we'll make it all pretty and we'll move on. Can't do that. And it takes a lot of time. And a lot of times I tell the people who I supervise, I say, however slow you're going, you want to back it up. No. Thankfully, both of these people I see on grants. So that is why I can see them for so long. I have had people in private practice who we have worked out like a sliding scale, or we've worked out like a specific, like we'll do 2 shorter sessions a week or something like that. So it really depends. Insurance does not like it. So a lot of times we end up having to do our own thing to make it work. Yeah, people think it's normal. Trauma is normal. It is not normal. And I think a lot of people are really afraid of dealing with trauma. And this is a really important point, is a lot of people who do OCD treatment are the same people who are really, really weary of trauma and don't get trained in trauma treatment. And you have a massive breakdown right there. I have had many people referred to me simply because the person who was seeing them knew how to treat OCD, didn't know how to treat the trauma. No idea what to do with it. And so, unfortunate reality. Okay, I'm gonna jump. These will be made available to you. um, but this is actually from my article. At this juncture, OCD and suicidality have been conceptualized on separate theoretical planes. Attachment theory may be the bridge between them, connecting our understanding and offering a framework for early and intensive intervention. I uh, I think that attachment theory really helps us out in this way. I think that it is I think it's a great lens when we're looking at all of these different things. So I would love to offer training on trauma. That might need to be more than 3 hours though. I could talk about that for a very long time. I've been working in complex trauma for a long time. Right. Questions. I know we're low on time, so I can also stay on for a few minutes after. If that works, Bonnie. I don't know. Works.
Yes, that can work if we're needing, or if we're having any questions, and of course you all have time. I do ask that we stay on for the remainder of the 4 minutes, but go ahead and ask your questions. And I do have some important information to share here at the end. So please don't log off just yet. If we are wanting to stay a little bit of extra time over, then that's great. But I would need to share some important information before. You might be able to take a question here or two. The feedback's coming in pretty quickly, so we're looking back at the questions here.
Additional trainings. Additional trainings on what exactly?
Yeah, go ahead and share your feedback, and we can go ahead and see specifically. I know there was already one on, I already took note of it.
Thank you.
Treating trauma, so make sure that you send those in. Specifically, what trainings are we looking for, and any other information. Let me go ahead and share my screen. That way I can share the information with you all. I know we are looking to get our credits, right? So I'll go ahead and share that information with you all here. Moment.
For ICBT training, highly recommend just going through their website. They put on trainings. They have consult groups that you can join.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.